Today, we're tackling contact dermatitis, a skin condition that impacts millions each year, but often goes misunderstood. According to the American Academy of Dermatology, contact dermatitis affects over 14.5 million Americans annually. It's more than just an itchy annoyance. It can cause significant distress, missed workdays, and even disrupt livelihoods. To get in-depth knowledge of how this condition is treated, I am so happy to have the opportunity to chat with Dr. Bruce Broad, an esteemed dermatologist who is the co-director of occupational and contact dermatitis at the University of Pennsylvania. Dr. Broad has a keen focus on inflammatory skin diseases, particularly contact dermatitis, and I hope through this conversation today that we will get a better understanding of the complexities surrounding the skin condition and how it is treated. Dr. Broad, thank you for joining us today.
Oh, happy to be here. It's great to be talking about a subject that's near and dear to my heart, very important for patients, and I think one of the most gratifying subspecialties in all of dermatology.
So, can you start off by sharing with us what contact dermatitis is and how it differs from eczema?
Yeah, it's really contact dermatitis is, we really think of it as exogenous. So it's caused by exposure to external substances that then result in dermatitis of the skin. I think it's always important when we think of contact dermatitis. I think the prototype that we can all relate to is plant dermatitis, especially living on the East Coast, poison ivy, poison oak, sumac, more in other areas of the country. It's really the same basic allergen. And a large majority of Americans are sensitized to that. But I think it's really important to remember that most contact dermatitis is irritant in nature. And irritants affect all members of the population. I mean, there's genetic variances in how our skin reacts to irritants, but I think it's important to realize that most contact dermatitis is irritant. And we may want to focus more today on allergic contact dermatitis because, it's a little more exciting to talk about. And different allergens, common allergens, emerging allergens, and where they exert their ill effects on the skin.
Yeah, it's actually very funny because I was reading the Andrews chapter on contact dermatitis, and it's very extensive. It goes into extensive detail about every single allergen possible, and it's probably not even the complete list, but it's amazing how many allergens there are. Could you just differentiate briefly the difference between irritant contact dermatitis and allergic contact dermatitis, just so our listeners can have a better understanding of that?
Yeah, for sure. And I think many of the strong allergens are actually irritant in nature. So it's in a sense, if you want to get into the weeds more, it's sometimes hard to separate the two because oftentimes allergens are irritants. But allergens or haptens, generally they're small molecular weight substances, and they elicit an immunologic reaction. It's a type 4 reaction. That's the hallmark of allergic contact dermatitis. Typically, it requires an initial sensitization process, and it's a complex interplay between Langerhans cells and T cells, setting up memory within the immune system, and then upon re-exposure, the memory cells trigger an inflammatory cascade, and the reaction begins again. Irritant dermatitis, that tends to be things that defeat the skin barrier, dissolve lipids, break down the stratum corneum, and are are cumulative in nature. So, typical irritants or soaps, detergent. I often remind patients, and I think even dermatologists and dermatology residents, that the most common irritant that we often don't think about as an irritant is water. So repeated exposure to water, the wet dry cycle, causing swelling, shrinkage, cycles of the stratum corneum is actually, I think, the most common and oftentimes under-recognized irritant.
So, which is actually, it's a interesting point you bring up, because I recently saw a patient who came in. I think she was saying that she had like hand dermatitis. She didn't diagnose it as that, but we were giving her very, clear instructions to only really have to wash her hands when absolutely necessary. And I think she had a hard time grasping at that, because everyone's like, well, shouldn't I always wash my hands? I want to be hygienic, especially with COVID. But we told her, like, this problem is not going to get better if you don't stop using as much water as you are on your hands and feet. I do want to ask you, we are seeing a rise in allergies. Do you see a link that, in terms of, are we seeing a increase in contact dermatitis as well? And do you think there's any relationship to epigenetics here?
I think allergy, I think in a broad sense of the word, it really needs to be distinguished from specifically allergic contact dermatitis and the allergies that we diagnose through patch testing. And I know, there are many factors that may be giving rise to allergies, and folks wonder about climate change and things of that nature. I think the critical thing to know, when you think about allergic contact dermatitis, is that it's, one, probably very much under-recognized, and I think there are many reasons for that, and I think a lot of it has to do with social determinants and patients. We did a study at Penn and found that certain segments of the population really didn't have access to patch testing the same way as others. So I think there's a high burden with contact dermatitis. It's really under-recognized. I think the common allergens, there are shifts. We see shifts over time as industry responds, as patient awareness goes up. I think that's the important thing, that it's really not a static field, and you have to keep up with trends in the literature to really be able to do the best by your patients. And it's very, very common. I mean, the most common allergen that we patch test to, nickel, there's a high rate of sensitivity in the United States population. It's less in Europe and other countries where they've limited exposure. But it's upwards of, there's gender differences to some degree, but 10-15% of patients have nickel sensitivity, and it's ubiquitous. It's everywhere.
Would you say there's any distinction amongst the demographics of who's affected by this?
Well, we think one of the ways folks are getting sensitized to nickels through body piercing techniques, and there is a correlation between the number of piercings and the rate of nickel sensitivity in the United States. And then, we have a great diff and diff type of study. If you look at Europe and look at the EU, and they restricted the use of nickel, the rates of nickel sensitivity have gone down in Europe compared to the United States.
So would you say there's any specific occupation that you see the highest rate of contact dermatitis?
Yes, and you're in it. Healthcare worker.
Lucky me.
I think the healthcare workers are a common occupation that I see in my clinic. One, I think because and it really took off during COVID, but it was common before COVID, and it's still common after COVID. Why do I see so many healthcare workers, nurses, physicians, especially, folks in surgical fields, people who work in the emergency room? Well, one, because they're exposed to allergens, and they're exposed to irritants, hand washing, gloves, antibacterials, even materials used in the OR, things like acrylates. It's a little less common. And I also think I see a lot of healthcare workers because I work in a large healthcare system, and the healthcare, medicine is challenging these days, very gratifying, and I feel fortunate every day to be a dermatologist and to be able to take care of patients. One of the positive aspects of being in healthcare is I think we know how to access the healthcare system better, and I think that accounts for why I see lots of healthcare workers, but also folks in the hairdressing industry. Is common in my clinic, cosmetologists, nail cosmeticians, really, really very common because of the exposure to acrylic monomers in the workplace, and a whole variety of other professions as well. And I think it really depends on where you practice. So machinists, but not as common nowadays. As now I've been in practice over 30 years, and the globalization and has caused shifts. So I don't see as many folks in industry anymore, because a lot of those jobs are offshore now. But I still see some auto mechanics, folks in construction, food handlers. So I think many of them end up having irritant dermatitis. It's one of the highest risk occupations for irritancy because of their exposure to water. So lots of cleansing, raw foods can be irritants as well. So those are really some of the common professions that I see. And I'm fortunate because I'm at a place where we have the ability to drill down and test to many of those specific fields. We have the allergens to match those professions.
So, that brings me to an interesting question. I remember seeing a patient, I think she was Vietnamese or from Thailand, and she worked in a salon, nail salon, and she was dealing with acrylic monomers, and she had a terrible contact dermatitis. These are difficult cases to manage because these jobs are their livelihoods. So how do you go about that situation? Obviously, the best thing to do is, avoid the offending agent and switch occupations, but that's not always an option. So what do you do in that situation?
Yeah, it's not always an option. I mean, there are alternative nail cosmetic products that don't use acrylic monomers, but they don't look as nice. Sometimes that shift is made. The approach to any occupational contact dermatitis is similar. First choice is try to substitute to substances that in the workplace that they're not allergic to. That's hard in the nail cosmetic industry because the alternatives aren't as good. But there are other things. I mean, just education, putting in engineering controls, keeping the surfaces clean and eliminating at least lots of contamination from acrylics, better ventilation, personal protective equipment. It can be helpful, in terms of face shields. Acrylates are pretty efficient at penetrating gloves, but using multi-layered or multi-laminated gloves can help at least to mitigate it some. I would say that's one of my most challenging occupations, and making that diagnosis, I've had to sort of temper my excitement over the years, because the natural inclination of a contact dermatologist when they find a relevant allergen is to celebrate and say, hey, look how smart we are. But I've been humbled appropriately. We learn from our patients over time to realize that's not such good news for somebody whose livelihood depends on that. And now, I get ready with the box of tissues because it often requires serious conversation and job retraining. It's hard sometimes to deliver that news. I try to frame it in the way that it's better. I tell my patients, I'm not really here to provide any specific, expectation. You're not gonna disappoint. Don't worry if you're not gonna be disappointing us if we don't find anything or we find certain allergens. I say we just want to be purveyors of the truth. We just want you to know the truth, because from that point, we're better off. We can establish a plan. We can take a step back, and kind of, if it needs some major life restructuring, better to know now than later, and make appropriate plans.
And, oftentimes those patients are coming to you after struggling with this for a very long time. And you kind of like, they finally found the right person to go to. And so for them, I'm sure it's also, partly a relief to know what, after all this time, what was causing it, because they try different things. They think it's something and it's not something, and they get misdiagnosed. So it's like hard to hear, but also it's almost like a bittersweet message to know what it is, but it's also hard to hear, especially if their livelihood counts on that.
Yeah, I think framing things, physicians, in the way they communicate and the way they frame things, and I don't know, if it should be this way. I think we ideally want patients to be able to be as independent as possible in making those decisions. But the reality is physicians do play an important role in frame things for patients. And there's ways to do that. I mean, this is good news, right? They don't need to be on an expensive biologic. That's a whole nother can of worms. Now we have some really, powerful, oral JAK inhibitors that might be that it raises some questions. I mean, we're getting to the point where we have medications that can control allergic contact dermatitis and might potentially allow patients to continue to be exposed to that hapten, for better or for worse. But it is a good way to frame for patients that, we have a treatment that doesn't involve drugs or medication or light therapy. It's just a question of putting measures in place to avoid it.
Have you found that you're starting to use these JAK inhibitors for patients that, that's kind of like their last resort?
It's very rarely still. Maybe I'm still maybe allergic contact dermatitis purist, and I haven't quite perhaps shifted to a more practical approach. I did have one patient whose livelihood depended on working with certain flowers, and she was hydrangeas that she reacted to, and she couldn't completely avoid them, and had pretty significant dermatitis that did improve on oral JAK inhibitor, and was able to use that in combination with minimizing her exposure at work. But
Fascinating.
it's still not my first choice. I'm still let's eliminate and substitute and educate.
Yeah, of course. No one wants to put you on a immune modulator if you could simply, change something without putting on a more extreme course. So I am totally with you on that. Is a patient with atopic dermatitis more likely to develop a contact dermatitis?
I don't think so. but I think that their allergen profile can be different, and I think there's a role for patch testing in some patients with atopic dermatitis. I think that, and some of the literature supports this, that atopics, they react a little more frequently to nickel, and they also react to some of the less potent allergens. One of my favorite sayings, if you've seen one allergen, you've seen one allergen. So atopics will tend to react mildly to certain allergens, fragrances, sorbitants, sesquiolate, emulsifiers, things like that. But my expectation in atopics, who tend to get referred to me when they're more recalcitrant or flaring, or they have certain regional accentuations, is that we're looking for something to help mitigate their disease, and set the expectation that this may not be the cure the way it is for somebody who's a healthcare worker without an atopic history, who developed hand dermatitis after the ED switched to a new pair of gloves, or somebody without a history of atopy who's now developing rip-roaring dermatitis on their dorsal fingers and face and eyelids, that gets better when they have a week away from the nail cosmetic salon. Those folks, the expectations are higher for cure, but with the atopics, I think it's tends to be more of a hybrid and a contributing factor.
It brought me to an interesting thought. Recently, my father is an oculoplastic surgeon, and he saw a patient who had ectropion, and it was actually caused by his glaucoma eye drops. And he also had developed a contact dermatitis to the preservatives in the eye drops, which I think is actually more common than people know, because he had said that he went to his ophthalmologist and that he has to be on these glaucoma eye drops for his pressure. But when we did a trial to take him off of the eye drops, he started to improve. But I do think it can be a challenging area, because obviously the pressure is like dealing with the glaucoma pressure is number one. And it's not always the case that you can find a similar eye drop without preservatives in it. So I was wondering if you ever deal with that situation.
This is actually a very common referral to my patch test clinic. These are really very challenging patients, and these are important patients to evaluate. I had a patient actually just the other week who is in need of ocular surgery, and that surgery would require post-surgical treatment with ophthalmic topical steroids. There's a problem though. This patient had a known history, and we proved it through patch testing and validated of topical steroid allergy, which is really very interesting. So what do you do? He needs steroids to optimize the post-surgical care, and he's allergic to topical steroids. So this was a patient and so there really needs to be a lot of coordination with the ophthalmologist. It really helps sometimes to have like a good pharmacist that can compound some things up for you. And so with this patient, we were able to test to a broad array of some of the steroids we have, and also some of the ophthalmic drops from the ophthalmologist. And we came up with, he's allergic to many steroids, but there was one Decadron, that did not react. And so that gives us a window to maybe a solution. The problem is there's no, like, he was also allergic to aminoglycosides, and there's Tobradex, there's lots of combo ophthalmics with aminoglycosides, but there really aren't ophthalmics with just pure Decadron. But luckily, our hope is there's compounding pharmacies. So this is really where I think coordination is the key here. You need good collaboration between the contact dermatologist, the ophthalmologist, oftentimes a compounding pharmacy, and be willing to patch test really broadly. And it's interesting because we think of patch testing as, hey, let's find the culprit, but sometimes we do patch testing to find the culprit, but also to find what's not the culprit. And I think those ophthalmology cases really tend to shape it through that lens, as opposed to finding the bad actors. It's also about finding the good actors. Benzalkonium chloride is a common ophthalmic preservative that it's in a lot of the agents, and it causes a lot of contact dermatitis. So preservative-free ophthalmic compounding pharmacies become really important in the patient's care.
Right. Yeah, that's what actually we had to go through a compounding pharmacy to see if they could make up what we needed so that he wouldn't have this. But definitely takes a lot of coordination and collaboration. Do you have a threshold for patch testing, or does everyone like kind of walk in and they get patch tested immediately?
Yeah, no, actually, a large part of my day, and there are other patch testing dermatologists on the team at Penn, but we actually have a really careful triaging mechanism at Penn, and we, as the patch testing dermatologists, we play a strong role in triaging the patients, because while patch testing is underutilized, it also takes patient time, it takes resources. A lot of the patients come from far away, even the ones that live close. Parking, in downtown Philadelphia at the University of Pennsylvania is not always easy. So I really try to triage the patients in several different ways. One, if it looks like the condition being referred doesn't fit so well with allergic contact dermatitis, then I might recommend further, especially if it's coming from non-dermatologists. I recommend, before using our resources, that the patient have further dermatology evaluation. The other thing too that I'll do is we'll look carefully, because if the patient has really widespread dermatitis, it can make patch testing really challenging. So in those instances, and this kind of involves walking that funny line, because we're triaging patients that we never saw before, but there's also sort of a certain amount of just do what's right for the patient. So sometimes in those situations, I'll work with the referring either dermatologist or allergist, or it could be other specialties as well, to try to guide them a little bit on how they might get the patient clear enough before they get referred into our clinic, because it's really a disservice to patch test patients who are flaring. You're gonna have trouble reading it. You're gonna have false positive reactions, and so one of the tactics we use to help referring physicians when patients are so severe they can't be patch tested is we'll give them preemptive avoidance strategies. Access to products that there's no perfect product in terms of being non-allergenic, but there are certainly products that are less allergenic, and so we'll work with the referring physicians, clinicians, and other licensees as well, to try to help the patient along, so that when we see them, we can do as optimal patch testing as possible. Sometimes it's not possible. Sometimes we need to do other things, treat them with systemic steroids for brief periods of time. Patients often are referred on other, immunosuppressants or biologics, and that sometimes requires a conversation as well.
Okay, so do you find, you mentioned recommending certain products. And I think that the cosmetic industry, as we know, it's very large, but a lot of the products contain preservatives. Do you think that this should be more regulated? And also another question I had was, you see these organic products being marketed heavily, and they say, oh, it won't cause allergies. And I personally recently had an experience where I went to get my makeup done, which I never do. And I told the woman I have sensitive skin. And she said, oh, this is a very organic product. It's clean. It doesn't have any like harsh chemicals in it. Sure enough, I got a reaction to it. So I feel like there's some like misleading marketing going on with the organic products. And I just wanted to see what your opinion was on this topic.
Well, you really ask two very good and separate questions. One is, do I think the industry should be more regulated? And actually, I guess not so regulated, because I think there are mechanisms in place now. There's a quasi ingredient review board, because the CIR, the Cosmetic Ingredient Review, that advises the FDA, and it serves as a guide for industry as well to use, safe levels or flag products that are unsafe. I mean, that's a group that includes dermatologists, allergists, toxicologists, and the like. And as you may know, the United States Congress passed the MOCA Act, and so there is going to be some increased accountability in the cosmetic industry. I think it remains to be seen, how that translates into patient safety, but that's going to involve more accountability for adverse event reporting, for companies of a certain size, registration of ingredients, tightening up on good manufacturing practices. So going in that direction, and I think it's probably a reasonable direction. I think we never really know the consequences of a law until we see it go into play. So I think that remains to be seen. So that's really one question. The second question is, do I think that the sort of like the clean beauty industry or all natural products could potentially, if I'm hearing you correctly, be misleading for patients? And the answer is yes, I do think that can be potentially misleading for patients. There really isn't a standard. There's not even a standard for, what constitutes, hypoallergenic products or products safe for children. I mean, there's some maybe very unstructured industry guidance on that. And, some companies do extra testing, pre-market testing on some of those products. But I think the clean beauty or all natural, of course, I think that's marketing hype to play on people's fear of, the harm of perhaps a synthetic product. And, I always go with my, maybe my cliche standard phrase of lots of natural things aren't that good for our skin, like poison ivy's natural and radiation's natural, and I think tobacco's grown, naturally, and that's not so good. So usually I think it's really important to, sort of, again, use some framing for patients, and, you're not going to get converts on every patient, but if you can at least make them stop and think. I mean, it's really all about the patient. We don't want the patient doing things that will harm their skin. And, it's a free market economy, but it sort of breaks my heart to see patients spending lots of money on chasing down, products for, false hope that is going to be somehow better or make them look younger or be healthier for them, reduce their risk for cancer, things like that, when there's not a lot of truth to that.
Right. And do you have any resources that you recommend to your patients for who are dealing with contact dermatitis?
Well, we give them lots of resources. We give them, I think that there's some links to low allergen products, but most importantly, we give them resources based on the things that they react to on patch testing, and try to put it in context for them as well. Disclosed conflict. I've been, president and on the board and all sorts of things with the American Contact Dermatitis Society, and I'm the AMA delegate. That's a really fun job, actually, that I have with them. But I use a lot of the resources from the American Contact Dermatitis Society, and I think any, buddy who's serious about patch testing should be joining the American Contact Dermatitis Society in addition to maintaining their AAD membership, because the resources are just amazing, educational for patients. There's the CAMP database, which is basically, if you think about it, it's precision medicine. We're talking nowadays about all sorts of genomic testing and biomarker testing, but I kind of like to remind people patch testing was the first precision medicine. We know exactly what's wrong, and we can tell patients to avoid it. And now we can tell them, hey, these are products that don't have in it what you're allergic to, with some quality control in place.
Well, Dr. Broad, thank you so much for your time. This is a very relevant topic, and I think a topic that, an area that is probably often misdiagnosed as eczema or another condition. So thank you for sharing your expertise with us today.
Yeah, no, happy. Thanks for inviting me. And I would say that, all dermatologists have, certain interests, and not everybody has the bandwidth to do patch testing. I encourage people to learn about it and do it, but if you don't do it, make sure that you have somebody in your community that you can refer to when you have patients who have potential allergic contact dermatitis, regional dermatitis, or unresponsive dermatitis, or, like we talked about, certain situations like, before a medical or ophthalmic procedure.
Thank you. I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.